Where is the record button? Because I'm
Are
on my
you
computer. Where's
are
that?
you on a cell phone, Ron?
No, I'm on a computer.
I do not have the option to allow you to record.
Oh, okay.
I'm not sure as to why. It just depends. It depends upon your device. Usually, it's cell phones that don't accommodate the recording. I'm not sure as to why on your PC that I can't allow you to record. All right, here. All right, just got a real basic image up here just to talk about some segments and intervals and making sure that we're able to recognize or most of the components to ECGs and just knock some dust off and make sure that we're understanding what we need to properly interpret basic rhythms as well as some basic 12 lead interpretations as well. All right, so remember, guys, your P wave represents your atrial depolarization. We want your P waves to be upright and round. Remember, the direction of your waves is in relation to the lead and the view that you're looking at that myocardium. And if that depolarization is traveling towards that positive lead or if it's moving away. All right, if it's moving towards that positive lead, you're going to see a positive spike off of your isoelectric line. If it's moving away, you're going to see a negative deflection away from that isoelectric line. So your P wave, that is the representation of your atrium, your sinoatrial node, depolarizing, producing that atrial depolarization. Your big interval here. Oh, let's see here. Gotcha. Your PR interval, right? That's the time that represents your atrial depolarization, and it incorporates the holdup at your AV node, right? And the holdup at your AV node is to allow for those ventricles to fill with what your atrium is pushing down or pushing through. And our normal PR interval needs to be less than 0.2. We determine that by counting our horizontal boxes. And when we see that our PR interval is greater than 0.2, we are suspecting that we've got an AV block, and then we start looking into our QRSs if they're dropped, if our P interval is changing, if it's consistent, and we start applying the rules of our first degree, second degree type 1, second degree type 2, and third degree AV block to determine the severity. Your QRS, right? Your QRS represents your ventricular depolarization. One of the hardest concepts of your QRS is, remember, they don't always have to have a Q wave, right? They don't always have to have an R wave. They don't always have to have an S wave. What they will always have is at least an R wave or at least an S wave. So what I mean by that is you may not always see 3 deflections for your QRS, or you may not see all 3 of these waves. And we pay specific close attention to that, right, when our QRS is noted to be wide. Wide meaning greater than 0.12 milliseconds. And when our QRS is apparently wide, we jump up to V1 and we look for that terminal wave in your QRS, meaning terminal meaning where that QRS ends in, right? What wave the ventricular depolarization ends in. And if it ends in a terminal R wave, right, R for right, we've got a right bundle branch block. If it ends in a terminal S wave, then we've got a left bundle branch block. So I know you guys may have, learned, bunny ears for right, big negative deflection for left. I mean, it applies. It could definitely be utilized, but to really make it black and white and to help eliminate some misinterpretations of morphologies, simple as this. If it's wide, go up to V1. If it ends in an R wave, it's a right bundle branch block. If it ends in an S wave, it's a left bundle branch block. Okay, let's keep it simple. And then we've got our ST segment, right, which is where the S wave ends, okay, and your T wave begins. If you have a terminal R wave, you don't have an S wave, we still refer to the ST segment essentially where that R wave would end and then your T wave begins, okay. The ST segment is a big portion of what we use to look for signs of ischemia or injury for myocardial infarctions or the beginning phases of an acute MI. And then we've got your T wave. Okay, your T wave is the representation of your ventricular repolarization. We like T waves to be upright and round in most leads. Some leads it's naturally inverted, like in your AVR. And remember, your atrial repolarization is taking place, but it's happening during ventricular depolarization, which is why we don't see that. Just some basic things to note about your ST segments. It's in relation to, you have your ischemia, which is where the surrounding tissue of that acute coronary syndrome is becoming hypoxic, right? Starting to struggle for oxygen. You start to develop some ischemic changes. Some ischemic changes may be ST segment depression. It may be T wave inversion, or it may be a hyperacute T wave, right? Those are 3 representations of ischemia. When we start moving into ST segment elevations, okay, we start considering injury, meaning there's starting to be some damage to the tissue that's surrounding that occlusion, right? That coronary artery occlusion. And the biggest concrete, way of recognizing an acute MI is if I see signs of ischemia, I'm looking to see if it's in continuous leads, right? Continuous leads means that it's looking at a heart that's perfused by the same coronary artery. And if I see ischemic changes in continuous leads, I'm then going to look in the reciprocal leads, or the opposite side to where that coronary artery is, to see if I have reciprocal changes, which would, for an example, be signs of injury, so elevations. And vice versa, if I come across injury type changes, your ST segment elevations, I'm then going to make sure that it's in 2 or more continuous leads, right? And then I'll look in the reciprocal leads to see if I find signs of ischemia, right? So your ST segment depressions, your ST segment or your T wave inversions or your hyperacute T waves. Now remember, there's some circumstances where reciprocal views may not be seen on your initial 12 lead, right? Especially if we're dealing with septal anterior ischemic or injury type changes. We've got to do a V7, 8, and 9 to look at the posterior myocardium to get a true reciprocal change. Let's look at real quick. I'll pull up this image of atrial fibrillation because it could be somewhat of a challenge. But if you guys can understand how we come across AFib with this EKG, I don't think you'll ever be able to miss AFib ever. So what's one of the first things you guys recognize in relation to this ECG? And let me put it in perspective. Here's lead 2, okay? So you put your patient on telemetry to 3 lead, right? And it views V2, okay? And this is what you see. What's your first initial kind of instinct? What do you think it is? Yeah, right. Your first initial instinct, like, holy shit, this person's in VTAC. I've got a wide complex. It looks to be fast. All right. And just to kind of get an idea here, we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. Almost your cardiac monitor is going to pop up with this wide QRS, and at your rate, it's going to be somewhere around 180 to 200 beats per minute, which is definitely fast enough to be considered VTAC, right? But you know, if your patient is stable, alert oriented, their skin presentation is good, they're able to make their needs known, we advocate for obtaining a 12 lead, right, to further, interpret this dysrhythmia to ensure that your initial interpretation is accurate. So we place them on a 12 lead, we obtain a 12 lead, and this is our printout, okay? Does your opinion begin to change here?
I mean, mine wouldn't.
Okay, so and I'm assuming it's because you're being drawn right here. You see that This is like, wow, that's wide, right? And it looks regular. Well, let's take a deeper look at it, right? And we have a long running strip of lead 2 down here. Look at your R to R intervals. What are they doing?
They're all irregular.
They're irregular, exactly, right? And VTAC, although it originates from the ventricles, 99% of the time, it's going to be what? It's going to be regular. So I've got an irregularly irregular rhythm. What's the only rhythm that lines up with that?
AFib.
AFib. So this is an example of, and do I have a discernible P wave anywhere?
No.
No. I don't have any discernible P waves. I've got no discernible P waves. I have irregular rhythm, but it's wide. Well, it's still atrial fibrillation, but it's got an aberrant conduction, right? It's got an abnormal conduction through the ventricles. And because of that, it's giving this VTAC look, right? But this is actually atrial fibrillation. And I fall back to my rules for the interpretation here. It's irregularly irregular. I've got no discernible P wave. That's atrial fibrillation, okay? If this was regular, then I would have to rely upon, all right, do I have extreme right axis deviation? Is the morphology consistent throughout most of the leads, most of the views, right? And then do I err on the side of VTAC? Well, our initial interpretation, we felt like it was VTAC. And then when we look at the 12 lead, we were able to recognize that it was irregularly irregular. And because of that, we rule out VTAC and we know it's atrial fibrillation. I'll ask you guys another question here, right? So for, let's say our patient is stable, right? Hemodynamically, their blood pressure is fine, their A&O, they're just complaining of some chest palpitations, and we see this, okay? And your initial kind of concern is you're really worried about VTAC. Can we use adenosine here?
No,
Why not?
that works on the atrium, right?
That's correct. But remember, there's two. So if I'm convinced this is VTAC, I wouldn't use adenosine because I know adenosine wouldn't work, right? But if there's a small part of me that says maybe it's not VTAC, remember adenosine can be diagnostic as well, right? I can try adenosine to see if it at least will slow this down to see that it is atrial fibrillation, right? Or B, it does absolutely nothing. So now I'm back on track where, well, because it's originating in the ventricles, the adenosine's not slowing it down, it's not doing anything. I'm going to go after amiodarone now. So you've got two options here. Let's look at one more AFib just to kind of. So if we look at here, right, now this is narrow and it's a little bit slower, right? It's a little bit easier to see what I don't have discernible P waves. I've got irregular R to R. It's atrial fibrillation, and the rate is 1, 2, 3, 4, 5, 6, 7, 8. About 80. Well, it goes back over here. So, but it's about 130 beats per minute. So AFib RDR. Irregular. Just to kind of point out, the big identifier on your atrial flutter here, might not be, is your flutter waves, right? That sawtooth type presentation here. A little bit easier to see in the computer generated A flutter. Real easy to see in this one, right? Sawtooth presentation. Now remember, atrial flutter can be a constant ratio of P waves to QRS, meaning it stays a 3-to-1 and stays a 4-to-1. It can also be a variant conduction where it's a 3-to-1, then a 2-to-1, then a 4-to-1. Those tend to be a little bit more challenging to recognize because of the change or variant conduction. We may be thinking atrial fibrillation. The constant ratio allows that pattern to form. It's a little bit easier to recognize those flutter waves, but we're really looking for the flutter waves to identify atrial flutter. Let's look down into our heart blocks. I just want to touch on third degree AV blocks because I feel like these sometimes can be the hardest to recognize. Let's see. So for this one, we move through our normal kind of approach. We look for upright and round P waves, QRS, wide versus narrow. Do I have a QRS for every P? Up, I don't. Boom. Okay, we've got some type of heart block here, right? And then I start looking at my PR intervals. Okay, here's one. Here's another. There's another. And as I move along, is the PR intervals changing? They are, right? So I've got a changing PR interval. And then if I think about, my heart blocks, well, that's either going to be a first degree type 1 or second degree type 1 or a third degree, right? Because a second degree type 1 is your going, on that produces the different PR intervals. And your third degree is your AV node dissociation, which produces the different PR intervals. Well, if I look at my R to Rs, what are they doing? They're mapping out, right? And because they're mapping out, there's no drop QRS. So right then and there, I eliminate my second degree type 1 because in your going, gone, your R to R is not going to be regular because of that dropped beat. That leaves one option, your third degree AV block. I would say a strong second interpretation here would be a second degree type 2 because these PR intervals, they look very, very close, right? So this would essentially be, there's your drop QRS, normal PR interval, drop QRS, normal PR interval, drop QRS, drop QRS. And unless you kept looking along, you wouldn't recognize the slight change in the PR interval, which would identify that third degree AV block. I would say I'd get a 50-50 difference interpretation that some of you would see the third degree and some of you would say second degree type 2. All right, let's look at some of the other things here, right? Don't forget about your ectopy, right? Don't forget about your premature complexes, moving into your premature atrial complexes, PACs, premature junctional complexes, your PJCs, and your premature ventricular complexes, your PVCs. So let's look at an ectopic beat here. So looking at this rhythm, right, we see kind of this area over here that's kind of got this beat that appears to be out of alignment, right? Not where it needs to be. Alignment right now. So through, I can see a P wave for my QRS. I'm getting a lot of feedback. Sorry, Justin, I think it was yours. Oh, maybe not. So by looking at this beat that looks out of place, I need to determine if it's a PAC, a PJC, or a PVC. Well, being that it's not wide, I know it's not a PVC, right? I don't see a discernible P wave, which would eliminate a premature atrial complex because a PAC is going to have its own P wave. And remember, your PJCs will present just like your junctional rhythms. You'll either have an absent P wave, an inverted P wave, or a retrograde P wave. So being that I have an absent P wave, it's a narrow QRS. I know I've got a premature junctional complex. And it's also very common to see or to locate that ectopic beat because there's generally an extended R to R interval after the ectopic beat. And that's essentially the heart gets a little startled with that ectopic beat, and that extended R to R interval, kind of its time of regaining its bearings. So I see this beat out of kind of context, out of alignment, not where it needs to be. A little bit of an extended R to R, and then it's right back into its underlying rhythm. We refer to this as the compensation phase. The compensation phase generally follows an ectopic beat, which is just an extended R to R interval. With your PVCs, remember we've got multifocal, unifocal PVCs, and that's in relation to if the premature ventricular complexes, they all have the same terminal R waves or terminal S waves, that would be unifocal. If some have a terminal R wave, some have a terminal S wave, that would mean they're multifocal. So looking at this ECG here, let's see, remove across, right? And we notice that there is a grouping of ectopic beats, right? One after another. And this would be an example of a couplet, right? Meaning 2 PVCs in a row. If there's 3 PVCs in a row, that is considered a salvo, right? Or a triplet, which is a run of VTAC. Can we manage our couplets and our salvos? Is there anything we could do to help kind of alleviate those?
Amiodarone?
We can try some amiodarone. What's the downside with amiodarone though? It's infused over time. It's got a super long half-life, right?
We just give them adenosine.
Well, the ectopy is coming from the ventricle, so the adenosine will also suppress that.
Can we try lidocaine?
There we go, lidocaine, sodium channel blocker, right? It's got a very short half-life. It's fast acting. It can help eliminate some of the irritability in the myocardium, and there's minimal adverse effects from lidocaine. But remember, when we do that and we eliminate all these ectopic beats, if they're perfusing, right, they're helping to maintain blood pressure. So if I were to eliminate all these ectopic beats and all I leave left is the underlying rhythm, I need to make sure there's enough underlying rhythm beats to maintain perfusion. So something to consider. But lidocaine would be a great option. Every time we see ectopic PVCs, right, or just ectopic beats in general, I like to make sure, or I like to differentiate, are they pulse producing or non-pulse producing? Because if they're pulse producing, that tells me that maybe this is a form of compensation, and I need to be considerate of that if I'm looking to alleviate the patient of the ectopic beats. And let's go. Just here's an example of bigeminy, right? Every other beat, we see a PVC. Trigeminy would be what? Every third beat, consistently, we see a PVC. All right, let's just get into some 12 lead interpretations, right? Remember, for every ECG, we need to start off with figuring out what the underlying rhythm is. And then we'll progress into our 12 lead interpretation that incorporates your ectopy, or I'm sorry, your aberrant conduction, your injury, ischemia, infarction, so on and so forth. So if we're looking at this ECG here, I come over and I'm looking for discernible P waves, right? I would say your septal anterior leads give you the best view of a P wave. So I know that it's sinus, right? It looks to be less than 0.2, so I don't have an AV block. My QRS looks to be narrow, so I don't have an aberrant conduction. My R to R is regular, so I don't have any ectopic beats. And my rate is 1, 2, 3, 4, 5, 60 beats per minute, so it's sinus. And I move into now my ischemia injury findings, and I'll come up to 1 in AVL, and I see an inverted T wave in 1, an inverted T wave with ST segment depression in AVL. So I have ischemic changes in continuous leads, right? And these are my high lateral leads, right? So with that being said, I want to go to this reciprocal view, and the reciprocal view of your high lateral is going to be your inferior wall, which is your 2-3 in AVF. And looking at 2-3 in AVF, I've got clear and obvious ST segment elevations in 2 or more of the continuous leads. And because of these reciprocal changes, I'm very, very confident that I've identified a myocardial infarction and or STEMI. So what coronary artery are we suspecting to be the culprit here?
Right.
DJ. So yeah, your right coronary artery, okay? And with your right coronary artery, a large percentage of people, their inferior wall of their right ventricle is also perfused. And with that being said, I want to look at to determine if my right ventricle is involved as well. I clearly can see my left ventricle is involved. And I'm going to do a V4R, right? So I'll move V4 to the right side of my chest. I'll print my ECG, I'll put a line through V4, and I'll put V4R here to be able to differentiate one print to another. And I'm going to look for ST segment elevation of 1 millimeter or more. And if I've got 1 millimeter or more, I know I've got right ventricular involvement as well. And I have to be very, very cautious with my nitroglycerin. A lot of these patients tend to be hypotensive or borderline hypotensive already, so it takes kind of the guessing work out of it whether or not you're going to withhold nitro or not. But in the event that they are not hypotensive yet they have right ventricular involvement, I recommend starting with a nitro drip versus a sublingual or nitro tablet, because we're going to take the dose from 400 mics sublingual down to 10 mics a minute intravenous. A little bit easier to titrate and ensure that we maintain a good blood pressure, a good mean arterial pressure, right, and good coronary artery perfusion. Remember, with your STEMIs, your acute coronary syndrome, we're talking about MONA or FONA, right? Morphine, oxygen, nitro, aspirin, or fentanyl, oxygen, nitrogen, and aspirin. Your oxygen, we're only going to consider it if their patient is suffering dyspnea or low saturations, right? Oxygen is a vasoactive medication. It produces vasoconstriction when it produces higher than normal PaO2. which is produced by the higher FiO2 that the nasal cannula or non-breather is providing. So make sure that we have a reason for oxygen administration in the event that we identify a STEMI. Our nitro, right? As long as our patient is normal tensive, no Viagra, Cialis, and we're able to safely administer the nitro. Do we have to have IV access to administer nitro? No. Is it good to have IV access with nitro? Yes. And then we're going to provide the 0.4 milligram or 0.4 milligram tablet or sublingual spray. I don't think anybody around here is still carrying the paste, which we would apply 1 to 2 inches of paste. But remember, after your nitro, continue to cycle your blood pressure, right? And continuously take ECGs to see if you start to see the coronary arteries dilate, which provide reperfusion, and you'll start to see these ST segments begin to normalize. That's a great sign. Essentially what that's saying is you're fixing the supply and the demand of oxygen, and because of that, the injury is subsiding, which is the main reason before I give nitro, right? Even if my patient looks gray, substernal chest pain, right? Radiating pain to the jaw and arm, get a initial 12 lead. Because if you get good coronary artery dilation with that nitro, you'll lose some of these ST segment changes. And we need these because at the end of the day, the cardiologists that work the cath lab, this is what they want to see right here. They want to see cookie cutter, clear as day STEMIs. That's what gets people to the cath lab the fastest. So make sure as you're preparing to give that nitro, you've got someone working on obtaining your 12 lead, and just give the 10 seconds to obtain that 12 lead before you give that nitro. All right, guys, we got less than a minute here. When we come back on, we're going to move into our written review, okay?